Good morning or afternoon, wherever you're at. I'm Kathy C. I am the director of the Childhood Communication Center at Seattle Children's Hospital, and I would like to welcome you to our 15th annual Childhood Communication Center Symposium. This is an annual event where we focus on serving kids who are deaf or hard of hearing. And so we present topics really that are relevant to people who take care of these kids and and serve these kids professionally, as well as families who are raising the children who are deaf and hard of hearing. And what we found over the years is that families and professionals seek high level information. And so we make these presentations very intentionally by inviting a national or sometimes international expert on the topic and having our local providers also help with the presentation. So I'd like to acknowledge our planning committee. Lisa Herber is central in making these events happen and happen smoothly. Janet Danell and Boulse-Archaro have really put this program together. This has been a program that's been in development for a few months, and we appreciate working with Dr. Wiley, our invited speaker. So the topic today is Deaf Plus, when it's more than hearing. And this has been a topic that's been a long time in coming. Every year we ask people to submit ideas for presentations, and Deaf Plus has been on the list for at least 10 of the 15 years that we've been making this presentation. So we're very happy to be able to provide this content. We are delighted to have Dr. Susan Wiley from Cincinnati Children's Hospital, who is an expert in this area and is going to give us a couple presentations that I think everyone will find very useful. We'll also have parent panelists who will share their experiences, and this is oftentimes a really informative part of the program. Now we'll do our land acknowledgement, and it's kind of interesting to do a land acknowledgement in this virtual world. Here in Seattle, we're going to acknowledge that we're on the traditional unceded land of the Coast Salish people, including the Duwamish people past and present. We honor with gratitude the land itself and the Duwamish tribe. This acknowledgement does not take the place of authentic relationships with indigenous communities, but serves as one way to honor the land we're on. And I would ask you to just take a moment to acknowledge the land wherever you are at today. So as far as some housekeeping issues, there's the link to slide handouts or in your reminders email, what they say sent out. If you handouts later and you can't find them now, you could email Lisa after this event. There are captions in the lower left-hand corner. Probably most people are familiar enough with this virtual format now. There's a little bubble with CC, and that's for closed captions. If you need the captions, you can click on that box and you can see the orange arrow demonstrating that on this slide. We have ASL interpreters this morning, Molly and Laura, and they are on the right-hand side of the slides. Then each talk will be followed by a Q&A, and we are going to use Slido for the question and answer. Here's the Slido exercise. So the question is, where are you joining us from today? This is fun to watch this. And so if people could enter where they're joining. Lost Washington, Portland, Puyallup, Oakland, Iowa, Spokane, Los Angeles, Alabama, Washington, Southern Illinois. All right. Thank you. All right. So today's agenda, we've done our program overview. And so it is with great pleasure that I will introduce Dr. Wiley, but first we'll go over this. She's going to give a talk on when it's more than hearing. We'll have a Q&A period followed by a 10-minute break. And then she'll give another presentation about autism spectrum disorders in children who are deaf and hard of hearing. And followed by another Q&A session. And then Tara Boulse-Archaro will lead a discussion on collaborative care and host some breakout rooms so that people will have a chance to discuss certain patient presentations. We'll have another break followed by our parent panel. So that's what the morning looks like. And now I'd like to introduce our guest, Dr. Susan Wiley. She's a developmental pediatrician and professor of pediatrics at the University of Cincinnati. She is on the Joint Commission on Infant Hearing. She serves on the advisory board of the Ohio Center for Deaf-Blind Education. She's a co-director of a CHARGE syndrome program at the University of Cincinnati and director of the Thomas Center for Down Syndrome. So certainly comes with a wealth of experience and expertise. And with that, I'd like to welcome Dr. Wiley. Thank you.
Thank you. That's a very kind introduction. I'm really excited to be here. We are going to try to stay on time as best as I can so we can kind of move that forward. I like to start with, I don't have financial disclosures, but there's a couple of, let's do this one. Sorry about that. My personal values are that I value individuals with disabilities and their families. I believe all people should have opportunities to fully participate in society, live healthy, safe, and self-determined and productive lives, and value the importance of interdisciplinary care as a foundational philosophy. So I think it's just helpful to frame that. And while I am still working on this, I do try to combat ableism and recognize the impact of intersectionality. So we're going to cover some factors and presentations which put children at risk for developmental disabilities, identify strategies to support families, and recognize the importance of interdisciplinary treatment. I like to quote Candace Lindown-Davies, who's been very prominent in Hands and Voices. Her description of deaf and hard of hearing plus is meant to be a positive term, not in any way negative or insensitive to the child who has medical issues along with hearing loss. In fact, I see it as an A+ or B+, meaning the child carries additional positive qualities, but is a gift that needs to be carefully unwrapped, and it may not appear to be a gift when you first receive it. Time helps you appreciate, understand, and unfold the possibilities. And the plus most often means the child and family has added responsibilities and requires additional expertise. I do want to make a statement about terminology because the newer terminology really is DHH with disabilities rather than deaf hard of hearing plus. So I think there's been some evolution, and I probably will pop back and forth. So why it matters to me is that maybe this isn't not or deaf and hard of hearing may be more common than you realize. And my goal, and families' goals as well, is to have their children achieve their maximal potential. But that combination of hearing and developmental disability can make it a little bit hard to know how we approach intervention. But I do know that when I see children make goals, no matter whether they're similar or different to typically developing peers, it's very rewarding. And that's what keeps me moving forward in my career. So if we look at the overall data, probably the most common data comes from Gallaudet Research Institute on school data and how children who are deaf and hard of hearing are categorized educationally. And in nearly every category, we see higher rates of disabilities as compared to the general population. When the CDC does a lot of evaluations of the general population. And aside from ADHD and specific learning disability across the board, I think ADHD and learning disabilities are harder to tease out in children who are deaf and hard of hearing. So it is possible that these numbers are skewed by how we evaluate children. I'm going to spend a little time on risks and etiologies because it feels like in the literature a lot of times people really hope that an etiology will be protective. So, if my hearing is due to this condition, maybe I don't have as much risk factors for other disabilities. But I think it's much more complex than that. So when we look at risk factors for hearing differences, these overlap with risk factors for developmental delay. And risk factors for developmental delay can
co-occur in children who are deaf and hard of hearing, unrelated to their cause of hearing loss. So when I look at risk factors for developmental delay in the general population, there are many neonatal factors, congenital infections, meningitis, along with other factors that can contribute to developmental delays. And when I look at risk factors for kids who are deaf and hard of hearing, even the risk factors for hearing loss, so those neonatal factors, symptomatic congenital CMV, bacterial meningitis, you start seeing this overlap that it can impact more than hearing. I do like to call out the family history of learning difficulties and attentional problems, because these are factors that we do need to be checking about, because that may give us some clues, an early clue of children's risk that may need a more different approach, or a more at least be monitoring for concerns in those areas. So I think the GJB2 story is kind of a good example of why etiology may be confusing. So early on, there were a lot of papers that describe kids with connexin mutations may have better post-cochlear implant evaluations, and other papers that suggest that they didn't. When we first studied kids, or when we first did testing for children for GJB2, we tended to focus on kids who we didn't have some other reason for hearing differences. And so there was a bit of a skew, I think, in what we were seeing. But it is clear from a number of papers that children with GJB2 mutations are not protected from other developmental problems. And so it's a fairly common mutation. And I have kids with two different, I have GJB2 and Beckwith-Wiedemann, or branchiotorenal. So there are these, you can have more than one thing as an etiology. So another kind of population to look at, there are two large studies, one from Nottingham and one from Manchester, looking at kids with cochlear implants and trying to kind of look at those etiologies and their rates of autism. So we start seeing a little bit of some trends, perhaps, in the cochlear implant population around congenital CMV, prematurity, and Usher syndrome as perhaps giving some additional risk for autism spectrum disorders. So, as this is where etiology may or may not be related and doesn't necessarily protect you from other developmental conditions. One of the areas, too, that I like to think about is just how important early intervention is. And we know that in the EDI world that we have this early recognition, early intervention to improve outcomes. Well, the same concept exists in other conditions. So when we think about autism, we also know that if we can identify children earlier and get them the right services, outcomes are better. And there's a lot of push to screen earlier, get interventions and diagnostics earlier. Similarly, kids with cerebral palsy are also, there has been an important push to try to identify children earlier. And there are algorithms with motor assessments to ensure that we recognize these patterns early. And that allows us to get targeted interventions. And, just to put those, keep that theme of overlapping risk factors, those risk factors for cerebral palsy include neonatal factors, symptomatic CMV, bacterial meningitis, and so forth. And the reason early intervention is important is it's about the brain. It is really about the brain. And why I like to put the head circumference there on the right is that you actually see this exponential growth of your head circumference, which is really driven by your brain growth. And in those first 2 years, we just see an expansion of the brain and hence an expansion of learning. The other factor of learning and development is the myelination and refinement of the brain organization. So those slides on the bottom there are really showing different myelination patterns across the age. And so you see a simplified pattern as a newborn to a much more complex system at 2, and then even more refinements into adulthood. So many people talk about myelination ending at about 25, which when you think about adolescence to young adulthood, there's still a lot of learning and why we might make some mistakes along the way, and then perhaps get our brain back as we're a little bit older. So I'm also trying to kind of weave some case examples to just really highlight why that early intervention, that early recognition matters. So this is a little child who was coming through our cochlear implant team and this family was super proactive. We had the referral very early, and this child was also followed by a neonatal clinic in another region. And I am usually, I am part of the cochlear implant team and usually like to wait close to, if we're doing it a little bit later, you just get a little more information when you're closer to one. So the team kind of thought, well, she'll want to wait. But when I reviewed the packet, what was striking was that he's a twin, born at 27 weeks, and had a very rocky NICU course where his gut had some infection requiring surgery. And so to me, those risk factors just pushed me to see him early. And while he was, if you think about him being premature and he was gestation corrected at 3 months, I think those who have been following him have been really keyed in on that 3-month gestation corrected. But I think it's the quality that was super important for this little guy because he was not visually tracking. He tended to have preferential looking to the right. When I pulled him to sit, so that you kind of wanted to see some head stability and tucking, maybe not quite that early, but he really still had a very significant lag. He needed a lot of support if he was on his belly to get his head right up. If he didn't have that kind of bolstering and stability, he couldn't lift his head. And he had rather wrist reflexes and what's called an asymmetric tonic neck reflex, which is this fencer reaction. And so, he just kind of would get a little stuck in those, kind of pull that back in. So the first step we did was, again, this wasn't going to keep him from getting an implant, but we did have him see ophthalmology and suggested imaging. And recognizing what I was seeing were early patterns of perhaps cerebral palsy. So again, early recognition and knowledge that we want to get kids in early. So we started him getting some physical therapy. Next one, please. So the ophthalmologist said his eyes were fine, and unfortunately, his imaging showed substantial encephalomalacia. So that's basically areas of the brain that had an injury pattern where there's areas of where there is not as much brain, and that injury pattern was there. So he has been diagnosed with spastic quadriplegia. And this is my attempt to go. The younger you are, a wait and see of 6 months is differentially lengthy in your life, right? So if I'm telling you to wait 6 more months at 12 months, that was half of your life for us to wait. So this is why, and I know, probably those in the audience aren't a wait and see folks, and sometimes pediatricians will say, well, let's see how things go. But earlier recognition does make a difference. Another paper I thought is kind of useful and helpful for us to be thinking about how to serve kids with more complexity is from Chapman. And they did a study looking at birth registry information. So they have the birth defects registry. So these are kids with known congenital disorders and how they cycle through our goals of 1 through 6. So screening looks pretty good. The black bars are the general population. The grayish is if you have 1 congenital disorder, and the white is if you have 2 or more. So you can see that kind of sliding down. Fewer children, about 2/3, will have screening by 2 months or by 1 month if they have 2 or more conditions. And then our diagnostics by 3 months is really, again, not robust for everybody. But again, you see that differential by the kids with more difficulties. And then the time between your hearing screening to diagnosis looks fairly similar, with a little bit later, a little bit earlier time frame between for the kids with 2 or more. But again, if you start that clock late, you're going to see delays in identification. So click that one again. Yes, thank you. What they suggested, which I think are very helpful thoughts, is one is, some of these kids spend a lot of time in the NICU, and is there a way for us to get that complete diagnostic prior to discharge? And that, I think, will help with this because it gets you on that timeline. And then the other piece that I think is very appropriate as well is when we know these kids have a lot of complexity and there's a lot of treatment things happening, can we do a better job of coordinating assessment? So not every system is set up easily to do this, but when we're sedating for one thing, can we add that ADR on? And those, I think, are just really important systems level things that we can advocate for. This was a paper too that distressed me. Now you have to remember, this is a study that looked at children who were not able to complete behavioral testing and required a sedated ADR. So this isn't the whole population, but these are kids that are difficult to test. It was a single institution, and they looked at children with autism, developmental delay, cerebral palsy, and Down syndrome. And what we see is, how old were they at the first behavioral test? And even that, I would say, again, maybe these kids had hearing screening, but we're looking at 2.5 to 3 and even older for children with cerebral palsy for their first behavioral assessment. And then they looked at when did they get their sedated ADR, what was that time gap? So you're getting anywhere from 8 to 20 months different between, gap between when that behavioral test occurred and when the sedated ADR. And then you also can then see the number of times we try, and it's good. We don't want to have to sedate children, but among kids with developmental delay and Down syndrome, we would try, 2.5 times. I know you can't do a half time, but on average, we were veering towards 3 attempts to get that before we did that sedated ADR. So I think I get very distressed about that for my kids with Down syndrome because I see it in my institution too. This is, they're not quite behaviorally ready. There's some fluid. And until we get a definitive recognition, then we're really pretty far out when we're thinking about intervening for hearing and supporting that access to sound. And as you can see, the rates of permanent hearing loss among kids with cerebral palsy and with Down syndrome are rather high, and they are the group that is the most delayed to get to that sedated ADR. Those rates of hearing in kids with cerebral palsy do kind of follow through. I've seen other papers of children with cerebral palsy, and about a third of kids will also have a hearing need. Next slide, please. We also did a data linkage project with our state data. So we looked at early intervention information where we had those kids who were we had age of identification, hearing status, and linked that to the educational agencies as well. So we'll push ahead. And what we were interested in, so just to give you a little sense, we did look at all of their IFSPs, or their individualized family service plan, which is supposed to be that roadmap of services that they're getting. Looked at those services, start and stop date. Go ahead, please. Yeah. And looked at their, a number of different categories. We looked at intervals. We looked at frequency. When did you start and stop, and so forth, just to give you a sense of what we were looking at. And then we also look at, any versus no services, cumulative exposure. So what did you get over time through the EI duration? In this basic demographic of the kids enrolled, I think I have a couple of arrows. So sorry if you could click one. We had about a 75% rate of Caucasians, fairly, 47% private insurance, and about 75% bilateral. And just those age of identification, you can see kind of ranging. The median was 3.9 months, so that 50% of kids got in by that, or were identified by then, but that range a little bit larger. I think I have a couple of. So again, this is you can just hit those. That's fine. So our 56% of kids did get in by 6 months, and this is pre-COVID. So I think our state data on the CCC looks worse than that at this present time. But 25% of those in EI had a documented disability. And those, again, communication may be linked to we also looked at the number of services received over time. So 60% of kids received 4 or more services. And that could be, we had a system where there were teachers with deaf and so forth. So those made sense, but then there are other services that may not be always linked to hearing. When we looked at the overall intensity of services, what we saw was a difference, what was driving that intensity. One was the degree of hearing loss. My slides again, I have a couple of So you see it, the minutes per month going up. Kids who with severe to profound hearing loss got about 15 minutes more per month compared to kids with mild to moderate. Bilateral got about 30 more, and kids who had prematurity had about 20 minutes more per month. So just kind of trying to understand those. This is also kind of a graph showing the change of intensity over time. So we have a number of different types of services here. We have the blue line, the light blue line is speech language therapy. The dark blue line are more like those teachers of the deaf. And, again, like you'll see that green line is physical therapy. So we can hit my little icons again. What we do see is a bump up in intensity of services from year 1 to year 2, and then kind of a plateau of that time over from year 2 to year 3, with the DHH services being fairly similar. But as you see, that speech pathology service is really bumping up by year 3. And again, what are we seeing here? Maybe there wasn't as much of a need, but maybe now that kids are supposed to be developing more skills, we may be seeing an increased need. And, I think we don't know the whys behind this, but I think it's interesting to look at that. What we thought was also striking is that these are 2 slides comparing those kids without disabilities and those with disabilities. So on the left, you see that our deaf specific or our additional services of speech and OT are kind of tight on the left in those kids who do not have another developmental disability. And again, you see that top line is the DHH services. Whereas the kids with diagnosed disabilities have a huge range in what they're getting, and at least in year 1. So, and the lower rate of speech language services. Again, there may be really good reasons for this, because maybe we're working on motor first and then communication. But I do think it's striking to see that big jump up of the speech pathology services by year 3 among these groups of kids. Okay, I think we can go to the next slide. I'm trying to keep my eye on my time. Oh yeah, those I got some nice little lines. Okay, so there we go. So on average, toddlers and infants who were deaf and hard of hearing got a lot of services, had more than 2 hours per month of services, and the degree of hearing loss, bilateral, and presence of disabilities was associated with higher intensity. And for those who remained in EI over time, we did see just a general bump up that seemed to be driven by the presence of disabilities. Another way for me to think about, hang on for just a second. Another way to think about, the way I think about development is, are we using a typical pattern and we're just taking a slower path and it's a sequential path forward, or are we doing atypical development, which is not the greatest word in the world, but you're basically saying I'm developing differently. So maybe I have some splintered skills. My pattern might be that I'm able to do it, but I'm doing it differently. So kids with cerebral palsy may walk, but their gait looks different than a traditional gait. Kids with autism may have great vocabulary but can't converse. So again, that's not usually the pathway that we see in those motor and language domains. Next slide, please. This is another slide that just really kind of thinks about kids' developmental trajectory. So the yellow line is kind of, I'm going to make my usual progress. At 6 months, I'm doing 6-month skills. At 12 months, I'm doing 12-month skills. That blue lower line that kind of plateaus are kids that are really probably more in that significant neurologic injury pattern. So I am going to make some progress, but I will kind of hit a max. So I work in an institution with kids with severe disabilities, kids and adults who have cerebral palsy, who cannot take care of themselves. They have value, they interact, there are things that they are able to do, but they have not gotten beyond a certain level. Green line is really more, the white line, and the middle one that kind of goes straight but never catches up. Those would be more the pattern that we see in kids with an intellectual disability. They do make progress, but they are not going to likely catch up to typically developing peers. And then that purple line is maybe those modifiable factors that a little bit of push and a little bit of exposure does really get get you back to typically developing peers. And why this is important to me is that trajectory. It's not one point in time. I have to see that trajectory over time to really understand where a child is heading. So the other factor, especially when I think about kids who are deaf and hard of hearing, is when language is the goal, can we see them achieve what is their capability? And often for kids who are deaf and hard of hearing, we look at that nonverbal developmental capability. And so when I think about kids, I read papers that say I have 6 or 8 kids with autism and receive cochlear implants, and some are verbal and some are not. Like, yeah, that's the range in autism. So how do we start understanding what should be happening in our kids who are deaf with disability? So one of the studies we did initially was looking at kids' nonverbal capabilities and their language. These were kids who were complex with developmental disabilities and cochlear implants, and we actually compared them to their typically developed their peers. So we actually had matched group for kids with disabilities. But what we found, you can go ahead and do, I think one of the, wait, you can keep there for a second. Yeah, this is going to be like fly in, fly out. On the left, it's a little bit confusing, but the bottom part of the graph really shows us our nonverbal cognitive quotient. So as the numbers go up, what we're also seeing is the language growth also goes up. So that kind of goes along with that cognitive capacity. However, it's necessary but not sufficient. So I want to make sure that it's not just about IQ. If you take all of the kids with cerebral palsy on the right and you map them out in their category, there is no pattern. So you see those kids with CP, and now you can hit my icon thing. But they line up really nicely with our prediction based on their cognitive ability. And that is why you can't just study kids with CP and say, there's a range. Yes, there is. Well, you can do that. There is a range, but there's so many components to that child's developmental pattern that are also important. I hope my interpreters are not flying too fast. I'm sorry. So I also like to make sure we really think about vision, because that is a gateway for learning. We learn our motor skills, we learn language development, our social recognize social cues. And so for kids who are deaf and hard of hearing, it's super important that we think about vision. And we may need to recognize risks for vision impairment and behaviors that suggest a problem in vision. So when we're working with kids who are deaf and hard of hearing, knowing some of those other pieces helps us identify that. And obviously that's really important for intervention because we may need a different approach. When we think about children who have vision impairment alone, so pediatric onset vision loss or vision impairment, there is a high rate of additional developmental concerns, up to 80%. And so that also just really, now we're talking, when we compare deafness and vision impairment, we've just really got to think about that collaborative approach and, call out to those deafblind projects and other services to help us support children effectively. These next couple of slides are just kind of some red flags and just helping you see, one, what are some risk factors for vision impairment? Well, there's some overlap with what could be a risk factor for hearing. And then just what are some of those visual milestones that could you go back for yeah, thanks. Are you noting objects? Are you tracking? Do you recognize yourself in the mirror? There's a lot of pieces that we need to be paying attention to. So, what can we understand from the literature on deaf and hard of hearing children? So, usually, go ahead and hit my next one there. They say children with X, whatever it is they've studied, do not make the same progress as children who are deaf and hard of hearing. That's not a surprise. So it's really hard to find literature that gives you comparison groups that allows you to take into consideration that impact or developmental level on outcomes. So I think I love to look to try to figure out, somebody has a new paper on some condition that's a coexisting, and I do try to learn from it, but it often kind of doesn't give us enough to go on to really guide families and understand what to do differently. And I like to talk a little bit about labels as well, because I think that can be both, it's a two-edged sword, I guess. One, a label doesn't tell me anything about a child. A child has Down syndrome, they have autism, even if they have Charge syndrome. I know certain things are likely to be there, but I don't know that child yet. What I've also seen is sometimes labels open doors. So sometimes advocacy and services and funding are driven by labels. So the autism community have done a very nice job advocating for school systems in some areas or services, ABA. And that can be helpful. And when kids who are deaf and hard of hearing with autism, and then maybe there's a door open that for them. But sometimes that label also closes the door. So I've also seen kids who are deaf with autism be told by a deaf program, we can't handle you, and be told by an autism program, we don't know what to do with your deafness. And so again, before they even meet a child, they may put some barriers up, and that's very frustrating. So I do try to advocate with families about that. But it can be, as I said, kind of two-edged. What I think is also really key is for early intervention, especially, you don't need a label to do the right thing. However, that label may be needed as you move into other services like school educational labels. And because schools tend to take a primary label and not, they think about everything, but sometimes that primary label then drives where the team is thinking. That's a really key aspect, really recognizable in the deaf-blind community. So our deaf-blind programs do a national census count. And so just looking at, this is a little bit older data, but looking at data close in time from the deaf-blind projects who recognize almost 9,000 children could be identified as categorized as deaf-blind, where about the same interval based on U.S. Department of Education data, only not even 1,500 were allocated or described as deaf-blind in their educational label, which means, doing the math, that's 16% of children are taking that categorization in the school district. Again, there might be a lot of reasons for that, and I think what we often see is multiple disabilities or multiple handicaps overarching the deaf-blind label. But if we're not thinking about the vision and hearing, what's being missed among those kids? Next slide, please. Just trying to kind of go through some learnings that I've had from families, and Charge is a great group of families to learn from. What we see commonly is just there's so many medical needs in early childhood, frequent and long hospitalizations. I hear stories of home nursing care, of the different shifts or the different people interacting with children in different ways or having opinions. Are they following the family's priorities, or do they have their own? Which really makes it harder for those kids to perhaps learn and have that predictability for learning. I see a lot of focus on feeding. I totally get that, but sometimes often it overshadows the thoughts about building communication. I like to also just help us remember there's a lot of parental trauma from medical experiences. So I think the trauma is real, and it's likely real for the kids as well. Yeah, and I think, one of the ways to think about these kids with more complexities, and if you can support kids with Charge, you probably have all of the toolkits, right? How do we help in those day-to-day moments? And, I say that with the recognition that sometimes families would also say, I can't do everything after a diaper change. So, but, in kids with Down syndrome, we'll often talk about do your diaper change, do a little tummy time for just a little bit. It doesn't have to be prolonged planks, and this Pilates time. So think about those snippets of time. I think too, especially for kids with a lot of complexity where they are having life experiences that are different than most kids, what can we do to pair meeting? Take that feeding tube to hold before you start the feeding. How can you help them anticipate what's coming? And especially for kids with Charge, we have to give them everything because they're input and output. So how they receive information, their communication, and how they express themselves may be different. So we really have to provide that broad model. So where I think I've led some changes, when I was younger, I really did kind of have this sequential thought process, like, right, so maybe, hearing's not, the access isn't good enough. And we've tried speech, now let's try signing. But what I've come to realize is that prolongs markedly the recognition of what is actually needed for kids with disabilities. So even if you don't know what the label is, we've got to understand the pattern. And then we try different things, we monitor, and that is where we're going to see improvements over time. I think from a family support perspective, I work hard. I try to remove parental guilt because every parent has it. I try to listen actively and not to respond, but to listen and understand. And that's, I'm still working on that through my whole life. And not just to kind of come up with the counterpoints. I think too, families can feel super isolated, and how can we link them to others? And some families have so many things going on; it's very busy, but they often feel not part of the deaf community and not part of the developmental disabilities community. I'm not understood in either area. Next slide, please. Definitely families, and I guess I have this in early intervention, but in every aspect, early intervention, in your clinical settings, in schools. Family is really the important critical component. They understand their child, they understand their cues, and they are going to help us figure out how to prioritize. I often talk to families about how do you use your goals, because there's so many of them. And we can be, again, in that concept of these are my priorities, but really what is the family looking and seeking? And that's where we really need to help support and move along. Next slide, please. So and why I say that is there was a family advocate with charge who basically told me I think I met her at 9 months, and I was like, holy moly. And they said, yeah, when we left the NICU and we had more than 40-hour work week for her between appointments and therapists, we realized you guys didn't know what you were talking about. So thankfully that family recognized and had the power to go, yeah, we're going to have to figure this out and not necessarily listen to everybody. One of the things I love about working in the Thomas Center for Kids with Down Syndrome is that the kids 4 and under, we sit in a room together. So OT, PT, speech, and nutrition are all there together. And what that allows is multiple perspectives together, listening to the family and deciding which is the next 1 or 2 things to be working on in the next quarter or 3 to 6 months. That also keeps families from feeling like everybody I go to says, do this therapy weekly, and all of a sudden they're overloaded. Next slide, please. A few thoughts on goal setting. So I always remember, people have taught me about goals, and I think there are important goals to think about. And then there's some exceptions. So one of my importances of family priorities was a story of a young man who had, maybe 10 or so, and he had a chromosomal abnormality, and he had autism, and he was happy and sweet, and he had ways to communicate. I think they had used some augmentative communication tools, but the school kept really pushing verbalization. And that family actually asked me, is it okay that we're okay if he never talks? Now that's a pull your heartstring moment, because I get teary with that sometimes, because I think, wow, they were there, they recognized who their son was before the professionals did. And we really need to respect that. And yeah, I was like, yes, it is okay, and had to normalize that he's valuable in who he is. And while there might be some goals that others have, it's okay if he doesn't reach them. The other goal tenet I had been taught is, make a goal so that. So I want my child to walk, and if there's kids with cerebral palsy or other motor delays, and but sometimes kids are going to get older and they're going to be fatigued and they're not going to be able to sustain that ambulation. So you got to think about, why do you want to walk? You want to walk so that you can play with others, so you can participate on a field trip. So that was a big framework. But then I met Oliver. So let's go to the next slide. Oliver lives in Nicaragua, one of the poorest countries in Central America. That is not popping up just yet. And every time we took a group of people down to Nicaragua, I'm seeing a next slide. Is that, can we go back and then start forward again? Ooh, there we go. It's maybe it's just me. I don't know. Well, anyway, he had some birth asphyxia and had cerebral palsy, and he was actually learning his letters and reading at 5, but he can't walk on his own. And so his family, you can move it forward, had built this walker system for him. So and they actually had him living with a different family who had better flooring so he could go and move around. We actually did a home visit, and he was a hoot because he loved running around. He was fast. He would bring things. He would try to scare us. And clearly we realized he was hard on his walker. Next slide, please. And I'm hoping this one will work. If not, that's okay. What I learned from Oliver, I don't know if you can hit the play if it'll go, is that it's just fun to walk and run. So I also like to use the words of Dr. Jones on rules to guide instruction. Focus on the donut, not the hole. I think that's one I try to remember every day that I come to work. What's in that? What are the things that kids can do? How do we use those skills? Celebrate all successes. I like this one a lot. If a dead man can do it, it's not an appropriate objective. And we see IEP goals of sitting on a carpet square, which is something a dead man can do. Not participate in circle, but sit still. And that, again, I think we have to frame those goals differently. And I think it's in this population, we do need to use meaningful context to make concepts explicit. Next slide, please. I know I'm close on time. Few more stories. Together we make a more effective team. So one more slide there. Oh, wait, we have more slides. So I used to work at this camp for adults with disabilities, and one camper had this amazing voice. She had an intellectual disability, but was super shy and anxious. And another camper, I don't know why, but she was not able to use her voice. So she did a lot of gesturing. She was very communicative, and she was a bit of a ham. So in the front of that picture is the person who cannot talk, lip syncing to the person behind her singing the song. And together they put on quite a performance. Next slide, please. So that's my thoughts on team building. Let's think about our common goals, listen actively. We've got to figure out ways to communicate across us. Know what you know, don't know what you don't know. It's okay if you don't know things. That's when we reach out. I have learned so much from the opportunities I've had to be in collaborative settings, just tons. And that is a great way if we can co-treat, be open to new ideas, think outside the box. We have to have a lot of creative skills in working with some kids to really get them further. And if it's not working, we need to change it and keep moving. Next slide, please. So I think I have this on both. Consider the radical middle, because it's not about a communication modality. It's about getting them further ahead. Next slide, please. And I just want to thank all of the families, children, professionals, who've helped me be a better clinician, person, and parent. And that we are right at 45 minutes, and because I put my little thing on here, and we're ready for questions. If I can stop this for you. There you go.
That was an amazing talk.
Thank you. It was a flurry, right? It was a flurry.
We covered a lot of ground. I think Janet and Lisa are going to, or the Slido questions are going to come up, but I'll start with a lead-in question. The slide showing the typical with the different lines of
trajectories.
The trajectories. It kind of suggests that it is a linear trajectory for many, and but you also said, or I think I heard you say that it isn't necessarily linear for some of these kids with multiple issues.
Yeah, I think the linear thing is the concept of typical development. And even I would say we use IQs a lot, which I have, some hesitation about, because the purpose of the development of an IQ test was to determine who would do well in school. So just understanding that foundation of IQ testing, but that's kind of that, we do expect kids to meet milestones along a certain trajectory. So, and then there's kids who meet them faster and meet them slower. But kind of when I think about the kids I'm seeing in front of me, why one time isn't going to be enough for me to. It's like a developmental curve, just like that head circumference. So I think the importance of monitoring kids after we've done things and thinking about not just, where does speech language pathology play a role of helping us follow, and are you making enough progress? Are you not making enough progress? What's holding us back? Who's on our team to really monitor the growth and development of children? I don't know if I answered your question, but
yes, no, it is. It's always very rewarding to see these kids over time and the families over time that they make progress and
right.
just at their, in their own journey. Janet, are you going to present the questions, or are they going to appear?
The Q&A is open for questions, and as they come in, we'll push them forward.
All right. Well, then I'll just keep asking my questions. So sometimes, maybe often, it seems like kids will hit certain motor milestones and then start to really accelerate as far as their development. Do you find that the case?
Yeah, no, I think there is a premise that work on your motor skills and then language will come. And in general, I do see that and I agree. But if those motor milestones are not coming along or not moving very quickly, I don't want to forget communication. So, and sometimes you will see, particularly with kids, say with cerebral palsy, language growth is probably going to be our best approach to understanding their developmental trajectory, because it's not going to, when you're little, it's how many blocks can you stack and can I do this puzzle and this and that and the other. And they're not going to have those skills based on motor disability, but not necessarily cognitive. So I think it's not always simple to understand, all the different layers and what might be interfering with progress. But yeah, I think there is kind of this tenet that once kids are walking, they're going to talk more. What I probably fear about that, because the kids that I see are the ones that didn't take off, right? So I'm seeing a subset segment. I'm seeing the ones that didn't follow, and so I guess not waiting too long to get the communication frustrations, behaviors that come from not being able to communicate.
Yeah. And we see that in all kinds of things. We see kids who are referred for drooling, when they're or something. And I kind of feel like, well, if you work on their oral motor skills in general and their posture and things like that, that their drooling is kind of a secondary problem. We don't need to do surgery on that or start.
Right. Yeah, it's a clue. It might be a clue to oral motor issues that are there.
Yes. Here's a question.
Oh, the radical middle. Okay. Well, I think what I'm saying is I realize that their families are very much pulled in different directions or guided for their communication modality. And I think kids can be successful in a lot of ways. And I think if we focus too much on one modality or another, especially kids who are deaf and hard of hearing with disabilities, we'll get lost because that just might not work as effectively for them. I even think about pictures and technology and how do we build these skills well beyond spoken language and signing. Sometimes signing is, you can tell kids really pick up on signing and that's going to be their way. They're gestural, and other kids are really auditorily minded and you see them using their voice. And so how do we take who they are and build those next skills? I don't know if I'm answering the question very much. You can check out that website, but I recognize that families are often really pulled, and I've had families say, yes, we go to a spoken language program and we sign at home and we just don't tell them we're doing that. And I don't think that that's as prevalent, as it used to be, that one thing is bad for the other. If you sign your child won't talk, that's to me not ever going to help anybody. Because if a kid's signing, hey, they're communicating and let's look at what's happening with their speech and receptive language through their audition. Is there a pattern there that we need to recognize?
Oh, great.
Yeah. Oh, go ahead.
Well, we'll take this one. When you're trying to teach a child sign language and or sign, it seems like too much to add a voice output device and app. What are your thoughts?
It does get tricky. And I think sometimes it also, you really have to look at, is more or is less more? That sounds weird, but maybe fewer things works better than more things. However, I would say we are actually working with kids who are deaf and hard of hearing with IQs from 60 to above average, and looking at the touch chat as a way to slow down and process and build sentences. When we presented that work at ASHA, there was a group who was actually adding sign videos with that. So we haven't really modified that for sign. The touch chat doesn't allow you to, I don't know, maybe it does, but we haven't figured out the signing support. But again, speech and sign are fleeting. And so how do we slow things down that a kid can retain what was said? And that's, I think, you really have to think too about what's making sense to the child. Is it the object? Is it the word, the sign? Where are they at on that level of abstraction, and move them up? And we'll have a little bit more of that in the autism talk. I don't have all the answers, I will tell you that.
Here's another one. Sometimes it can be difficult for families to understand their child cannot make more improvements. How do you address that with your patients' families?
Yeah, that's a great question. I try to be balanced. So, meaning I don't want to take away all hope, but again, it's that progress over time. And so have you hit a cap? And sometimes I don't give up right away. I have, particularly for kids with more speech production issues, I will sometimes, when they're 4 to 5, talk about if a child's not really talking meaning a lot by 7 or 8, I don't know what is a lot, but if we're not really seeing that speech take off by 7 or 8, it's unlikely that speech is going to be the main way a child's going to communicate. It doesn't mean they can't still learn some words and make some words, but they may not be clear enough to have meaningful communication. So I try to some degree, kind of, particularly if I'm seeing kids over time, when are those benchmarks of, we're going to want to look at this rate of trajectory at this point. I don't think about 3. I think about kindergarten, first grade. How much gap have you closed? How much have you not? Sometimes we have to go back to, there are neurologic issues or there are genetic issues that we understand maybe to some degree the variation in outcomes. I think I don't want to take away hope, but I also, I guess I'm also like, well, what else do we need to put in to keep things moving forward? Sometimes, I guess what I'm like, so you might be kind of, maybe the question is around, we got to move to another communication strategy. And I guess I do a lot of educating how this approach doesn't keep you from your goal, but it might be the link to get you to your goal. And I'll talk about that with a kid with autism this afternoon, where we are a little bit later this morning. I don't know what time it is there. Sorry. That we use picture exchange communication to get him going. And he uses spoken language now. So, but if we hadn't done that, I don't think he would have ever gotten to that next phase. So if it's around communication, sometimes it's like, what is working? I've had some other kids come through the cochlear implant team who already have very clear recognized delays. And my conversation is, we should implant. Sure, I don't know, because learning has been hard in other areas. It may take longer for the child to respond to the implant. And I did have a family come back much later, and they had fostered to adopt this child with a pretty substantial intellectual disability. And they said, you were the only one that told us that wasn't, that gave us caution, I guess, or gave us pause. And you were right. He's only gotten this so far. So I don't know that you have to like hammer it in every time, but eventually families do recognize this is where we're at. I mean, I think it's an evolution for families, and I think the family panel may give us some real, how do we support families when they're still trying to keep that hope, but they're starting to worry too, or, there's still the positives about the kid, and how do we promote those?
Thank you. We have one more question, and then we'll take a break.
Okay.
In your opinion, what is the most important thing we can say to encourage families who are handling so many complicated issues?
I think that's a great question for your panel. Probably it's like, what can I help you with? What is your priority for me today to kind of focus on? I mean, I start my visits with, like, I've looked through your chart, but I like to start the visit with what is most important to you, and I'll round the other stuff out. Like, is it important that I check all of my anal check boxes, or am I trying to understand what you are needing help with right now? Is it tantrums? Is it sleep? Is it communication? And we start there, and then I might have to figure out some of those other things and how it relates. But, if you don't help with what they're wanting help with, you're also I'm not going to see them back if I didn't address their concerns. And sometimes it's, maybe be outside your scope. And then okay, I don't know, but I'm going to link you with social work. I'm going to link you with, this program. Let's try to figure out who's the resource and support to help you in that. And I know I live in a super resourced location, so I'm very blessed. I know those resources aren't everywhere, but how do we link you with what you're currently needing help with?
I think you live in a resourced environment, but I will say that it is also amazing to have a developmental pediatrician with your perspective, because many of us, I'll say, come at it from a very specific direction. And so for me, I'm an otolaryngologist, and I focus on the ears and hearing and communication things. And yet these families have so many other things going on by definition that that having a great developmental pediatrician as part of the team is an amazing resource for the family. So thank you.
Sure. Thank you.
Break, and,
sounds good.
And we'll be back, and we'll reconvene at 9:45 sharp, 6 minutes.